So this is Ash, and this is my five-surface amalgam. This is a case I just recently did yesterday, and I was thinking let's just post it on this YouTube page because I think there's a few tips I can that over 20 years of figuring how to do these I can share with you. This is a great restoration post endodontic treatment, especially if there's already previously an amalgam, if there's already a mesial and distal box placed. In this case, this is stage two actually. This is before we got started. I'm not going to show you the endo. We just finished the retreatment, but I wanted to show you where we started. So we had a mesial box here, a distal box, and the next image you're going to see is the endo's already done. So this is the distal, this is the buccal, here's the mesial. Now what I've done is to keep the sodium hypochlorite contained, we removed all the restoration, but I just kept the distal and the mesial portions to act like, just a reservoir. So what I'm going to do then is we're going to remove the mesial and distal boxes of the Fuji. So what we did here is we finished the endo, then simply I took the clamp, moved it to the 7. Now if you look at this, it looks like you're going to be like, whoa, what's going on here? We started this is a necrotic tooth with a large apical lesion, and we've elected to just let it sit with sodium or with calcium hydroxide for several months to see if we get some healing. So that's what's going on here. So let's go ahead and we're just going to prep out that Fuji 2 restoration. The amalgam restoration, especially the treatment or the patient base that we have where I work right now, is a very high caries risk, army type of situation where we need these patients to be deployed immediately. Not immediately, but essentially not waiting for crowns. We're just filling and drilling. Lots of caries. The amalgam restoration, although it's not taught in school a lot anymore, unfortunately, I mean this is a great restoration that'll serve a decade or two, and it can be done in quickly once you get good at it in one sitting. I'm getting these done now in about 30 to 40 minutes, and then the patient's fit. I know at the beginning it was painful. Trust me, that's why I'm making this video. So what we've done, let's go ahead and we're cutting out a bunch of stuff. So we've removed, because I don't need to sit and watch this. So this is the distal. The Fuji's all gone. So rinse that out. And then what we're going to do is, I think the mesial is gone as well. So we're going to make sure we have adequate reduction. Now, adequate reduction means, minimum 2 millimeters of reduction. When I look at, so we're just taking the long shank diamond burr. I've already actually I did not depth cut this because it was already reduced before, and I just wanted to make sure. And what I'm doing is I'm looking at the adjacent teeth and eyeballing 2 millimeters. Don't go cheap on your reduction. What I'm doing here, this is a really important thing that my buddy Major Mahmood had taught me, was to round the internal line angles. So when you're starting to carve this restoration, you're not having sort of a point of a stress point when you're carving. Not so much when the restoration's in function, but when you're carving, and then the whole thing doesn't fall off. Now I'm always looking at my adjacent restorations. This is a little bit out of focus. We're going to be replacing this restoration anyways with another 5-surface amalgam, so I'm not going to actually touch this up. I can't. In this case, I don't show it, but I actually recontoured this premolar. The amalgam was fine. Let me see if it comes back in here. I recontoured just a little bit. I don't think I caught it in the video. And then, so we recontoured. Oh, yes, we did. So you see how the contact is really flat. So what I did was I just took a finishing burr. I slowed my handpiece down because it's electric. And then we kind of brought that contour in like here. It's important to look at the adjacent teeth and make sure you have the proper contour, make sure there's no caries, because now we have, full access to it. You may be thinking, wow, there's not a lot left of this tooth, and quite frankly, there isn't. This is kind of the last leg for this tooth. We were getting success with placing calcium hydroxide and retreating the distal, so we're going to restore this, and maybe we'll get 5-10 years out of this tooth. Now, if you're not familiar with the Auto Matrix, this is my matrix band of choice for the 5-surface amalgam. You can use a Tafelmeyer, but you have to kind of finagle. The problem is with the Tafelmeyer, you've got this thing sticking out that acts as a lever, which can be difficult to obtain, proper seating. But more importantly, with the Tafelmeier, where the two pieces of the band come together, there's this huge gap, and the Automatrix kind of eliminates that problem. You can facilitate fixing that problem with the Tafelmeier by adding a little piece of, cutting a piece of Tafelmeier and sliding it in, and then tightening your Tafelmeier. But honestly, this is so much easier. So we're just placing the wedge. Normally, what I'll do is I'm going to use a flat surface instrument. Don't use the end of your cotton forceps; it doesn't really help. Normally what we'll do is I'll tighten, this is, you'll see how it's being used. So we seat it, this is a regular wide. I'll normally seat the band, tighten it, and then place my wedges. In this case, for some reason, I don't remember why, I wedged it and then tighten it. I prefer the previous because it's a little bit easier, placing the band, tightening it, and then placing your wedges, but it appears that it doesn't really matter. Now, this is really important here. A lot of my new dentists are reseating their band until they get rid of this gingiva. Don't do that. You take your Explorer, and once you have your wedges in, cut that right off and clean it out. Take your Explorer and clip that, clean it back and forth, and then you're good. So we've cleaned out everything. It's really important, even though amalgam is a little more resistant to, okay, so we're going to take our wrench, we're going to tighten that down. I'm trying to make sure that this little clip is on a piece of a lot of tooth structure, if you may. In this case, it turned out it wasn't, and that's okay. So I'm going to turn it till it clicks, and then here we go. So there's that in the mesial box. You can see I'm trying to clip. What I'm doing is I'm taking my Explorer, running it back and forth along a gingival margin to clean all that up, to get rid of that. That looks like a little bit of fracture. I don't think it is, though. It's just staining. So, and then on the distal, so we're going to clean that up by running my Explorer back and forth. And then I don't reseat my band. I'm just talking to my dental assistant about it because she was watching her new dentist as well. So run that back and forth and then clean it. I can't stress that enough. We'll clean that out and then we'll get a dry margin. Just like on the distal there. So we're going to rinse that out. And then the next stage, so let's rinse all that out. The next stage is we're going to burnish the matrix. Now, what you're going to see, I was talking so much with my dental assistant because I just started working with her. Okay, so this is the mesial. I'm happy with that. It doesn't look that, in real life, it looks a little bit different. I forgot to burnish the matrix. So you'll see me burnish it. This is this video doesn't have all the instruments that I normally use. It's just kind of what I have. So one of the things, so you're going to see me burnish it in a sec, but one of the things that my mentor taught me many years ago when you're placing amalgam is take it in the box and push it back and forth, buccolingual. And what that does is it fills it. See what I'm doing is I'm trying to fill in those nooks and crannies right there. So run your condenser, your packer back and forth buccolingually just to fill in those nooks and crannies, just like that. So we're going to place lots of pressure using a small condenser up front in the beginning of the placement of the restoration. So at this point, I'm like, oh, I haven't burnished my matrix. So I'll grab the next condenser, and then you'll see me grab not the proper like acorn burnisher or anything like that. We had whatever. We do have an acorn burnisher actually in the kit. We found it. I'm just going to use this type of instrument. It's good enough. Anything to just burnish that band. The thing that you might be used to using with the Tafelmeier is to release it. The Automatrix is really hard to do that as you're using it, to release the tension on it so you can maybe get a better matrix or a better contact. But I've used it for 20 years now and it seems to be okay. If you're not familiar with these types of amalgam carriers, they're way better than the other metal ones with amalgam on two ends. Those are terrible. I can actively and quite confidently say that. All right, so what I'm going to do is I'm going to fast forward. You're just going to watch me pack in all this amalgam. That's pretty standard. We'll fast forward all of this. One of the things that old timers we were taught when we were doing amalgam is that if you want your dental assistant to place it, it's a nonverbal cue. You can say just place it here and then put it, or just say place it here and then leave your amalgam carrier where you want, or your condenser where you want them to place the amalgam, I'd highly recommend getting your dental assistant involved rather than just packing, you getting it, them passing the carrier to you, and then you packing it, or putting the amalgam in and then switching back and forth. Like, just get them to place it where you want it. It's much faster. Because what we're going to do is when we're carving this amalgam, it's really critical. We're going to do it in 2 stages. So the carving comes in pretty much 2 stages. The first part of the stage, carving, is we're going to address anything that we can't. The patient was sleeping and he was mouth breathing, so that's why I made these little clips actually in the rubber dam so he can breathe through his mouth. It's pretty handy actually. So the first part of the addressing this amalgam restoration is, let's go ahead and speed this up, is tackling anything we can't adjust with a burr. What does that mean? We're going to adjust our occlusion at the end. We're going to try to adjust contour anything that is going to be like our gingival contours, our buccolingual contours. Those are really hard to do, especially if you have an overhang. Those are tough to take a burr to. So we're going to use the interproximal carver. That is probably the most important instrument of this whole technique. You can use an explorer, but the interproximal carver has a bunch of contours and it's really sharp. Sometimes you'll see it called a scaler. It's an interproximal carver. It's got a beautiful angle, so it'll work on these restorations as well. So what I'm going to do here is when I'm filling it, I'm looking at the relative height between the adjacent teeth, and then I'm going to take my explorer. And what I'm going to start doing is I'm actually going to start removing amalgam all the way down to tooth structure. That's the first part. And this way, again, this is the first stage of the approach of restoring these types of teeth, of carving these restorations. We're not going to, I will adjust the occlusion if it's way off, like up front, but I can do that with a burr, no problem. This stuff is really hard to deal with a burr. So buccolingually, we're going to take our explorer. You can use, sometimes I'll use an explorer, sometimes I'll use the interproximal carver just to get kind of in between the band and the tooth structure. So I'm slowly making my way down to tooth structure on the buccolingual. I'm also trying to establish my occlusal embrasures. Those are really important because I'll tell you when that amalgam's set, that's a real pain in the butt to try to adjust when you have essentially a little piece of steel in somebody's tooth. So we're just going to work around. So I'm not going to do this in high speed. You'll see me just slowly make my way down. And then what I'm going to do is once I make my way, I know that I'm contacting tooth structure. That first of all then gives me an idea how much amalgam I placed. So if I have enough thickness, because we need minimum 2 millimeters of thickness of this restorative material to be effective in fracture. Then the other thing is that then I can start pushing the band a little bit out. So what I can do is then slowly, as I squeeze the band outwards away from the tooth structure, then I can get closer into where my gingival embrasures are with my instruments. So what I'm going to do is we're going to clip this little clip. Now you can see that this is so much easier done with a rubber dam on. If you've never extracted a tooth with a rubber dam on, I highly recommend you trying that. So this clip is really dangerous. This is something that a patient can aspirate. Right here, this little clip here, it keeps it together. So having a rubber dam on while you're doing the procedure really makes it so much easier. So what I'm going to do is I'm going to open this band up like a Christmas present, like my kids do at Christmas, and then I'm going to slowly just adjust my contours, my gingival or buccal contour in this case, and then slowly, like I said, I'm going to slowly try to weasel the band this way and try to adjust more of these contours. So the beauty of this instrument, this is the interproximal carver. Both sides have a different angle. You can use it to carve so many different angles. So here I'm doing, this is the buccal, I'm just adjusting that buccal contour. And then I'm going to get interproximal and get into that gingival contour. What we tell our dentists here, that these are not beautiful restorations. The uglier, the better. The uglier means that potentially you've spent more time adjusting the gingival embrasures and the gingival tissue, making sure that you're going to get great contours and no overhangs, rather than spend all your time on the occlusion. All right, so I'm trying to weasel this little clip out of there. Actually, what I'm trying to do is open up this. See, this wedge is in the way. So I think I'm going to actually take this wedge out soon. So what I'm doing is I'm trying to address the gingival embrasure on the mesial box here. There. So what I'm trying to do there is I'm trying to slowly, see how the band is slowly moving towards the lingual? I'm trying to do that so I can get a little more space in there. And then I can get, start carving a little bit more along. You're going to hear me say gingival embrasures many times because that's the main problem with these restorations. Other than them breaking while you're doing it, is having overhangs and whatnot like that. So you haven't seen me really adjust the occlusion at all. I'm getting frustrated with this stick in the way essentially. So we're going to open that up and then I can address more of this mesial box right here. One of the things my mentor taught me as well is that when you're making finish lines, especially for any type of restoration, make them straight and flat. Not like this one. See, this one I didn't spend a lot of time doing it. It's kind of like jagged like this. It's hard to make a perfect, really nice restoration finish line to that. Don't do that. Make it a straight finish line. All right, so we're just carving all these contours. And again, I can't remember if I use a burr or whatnot, but if you do use a burr, just take it, you can use your electric handpiece, slow it right down to like 5,000 RPM, use a large number round 8, and just adjust the occlusion at the end of this. All right, so I'm slowly trying to, oh, there we go. So I was trying to move it towards the lingual so I can get more access. So one of the things that you're probably going to say is like, wow, there's lots of hemorrhage. Yes, you're going to make the gingiva hemorrhage significant amounts because we want to make sure we don't have any overhangs. So what we're going to do is we're going to place our packer on the marginal ridge there and pull it up. There is a little hook here. You can place that interproximal carver and use that to pull up and away from the restoration. There's that. And then we're going to take our, sometimes, I'm sure you know what I'm talking about when the cotton pliers don't work. Sometimes we'll just have to take a pair of hemostats. I was able to weasel it out. There we go, out it comes. So now we're not tackling the occlusion again. Now the most important thing is to get interproximal. Say it with me. Gingival embrasures, most important. So this is the beauty of that interproximal carver. So it not only has a hook this way, it also curves another way. You have to see it. It's a beautiful instrument. So that's what I'm doing. I'm getting subgingival, and I'm starting on 2 structure and carving coronally. I gouged it a bit there, so you got to be careful of that. But this is just, like when you're making art, it's, halfway through the art project or the thing you're building, it looks like hell. So go with me here. So you can see there's that curve. It is hard to get this instrument in lingually. So I'm trying to weasel my way as best as possible. I'm going to do most of the work from the buccal, but I still need to address it from the lingual. So not only is this instrument great for doing what I'm doing here, it's great for carving that buccal, it's great for carving that lingual. And it really is the only instrument I'm going to use for most of the preparing a lot of the contours. It's super effective in doing all of that, achieving all of these contours. Yes, the patient's gingiva is going to be sore, but that's easier, it's easier to heal it once you've got great, smooth flowing embrasures versus a huge overhang, and then the patient has to get surgery or the restoration redone. So what I'm doing here is I'm touching as best as I can feel onto structure and then pulling coronally. Same thing here. And you can see how many times I do this. And really the key for me is to make sure we don't have any overhangs. Because the contour is super important. Again, I'm not going to win any artistry awards here from this restoration. Okay, so I'm happy with, at this moment, I'm happy with the embrasure space. So let's go ahead. I'm just going to speed this up. There is a great instrument called the Clapton. It's a huge instrument. It wasn't in this. That's a normal. This is an endo kit that we have, so we've got bare minimum. But that's the usual instrument I'll use for carving these large amalgams is a Clapton, because then you can make, you can remove a significant amount of two structure of restorative material. My mentor taught me 20 years ago now. We're just trying to make sluice. He called them sluice ways. I still don't know how to say it. Anyways, just a track mesial-distal for just for food to kind of path, or just even for just really basic. We're not gonna. This isn't going on the cover of the most recent operative dentistry textbook because no one's doing this. But I'll tell you, these restorations, I'm sure you've seen them, can last damn near a lifetime, maybe not quite a lifetime, but a pretty long time. So one of the things that my mentor taught me as well, when you're carving marginal ridges, carve towards the center of the tooth, not like, for example, mesial. I'm not going to start here and pull towards the mesial because it'll break that marginal ridge. So I'll push away. So I'll pull from on the distal and I'll push like that. I'm keeping the tip. I'm trying to keep as much as possible the tip. If I'm going near tooth structure, I'm going to keep the tip on tooth structure, like around the contours here. And then what I'm doing here is I'm looking at the adjacent teeth to see the levels. This Clapton instrument is really large, so you can actually run it along the marginal ridges of both, and that gives you a great, quick method to adjust your marginal ridges to the adjacent teeth. I mean, 99% of the time, all the marginal ridges match. Again, I don't have the instrument in this kit, so I can't show you to do that. But it's a really simple way to do it. You can do that with a really large discoid cleoid, is to run it along the adjacent marginal ridge. All right, so we're going to rinse off all that amalgam. Let's take a look here. Again, I'm not winning an Academy Award for how my amalgam looks. We're going to get our contact. We're happy with that. Get our contact here. That's good. So I see a little bit, I think this is where I see it a bit here. I'm going to get my dental assistant to rinse out these amalgam bits. Never pull up. That's just asking for, even if it never happens, pulls your amalgam out, just don't floss and then pull out like that. Don't pull up because you could be like, oof, shouldn't have done that. And then we're going to check our gingival embrasures. There it is again with our Explorer. Making sure we have no overhangs. And it's purely a tactile sensation. We do have a post-op PA. It's not really going to show you much. It's post-op PA after the endo was done, and then we have a restoration. Here I'm just doing a little bit of burnishing, pretend burnishing. Burnishing is really used to smooth, to kind of move the material towards your margin and then smooth these margins off. Smooth around all the contours and whatnot. I mean, we're burnishing margins closed, but it's also to smooth everything. This is the time to do it because once that amalgam's set, it's really hard to smooth it out. So wherever it's in contact with gingiva as much as possible, obviously interproximal is almost impossible to do it. And it's not really designed to, burnish the surface. You can, I'm going to do it here, but it's not, burnishing can do that, but it's more just where your margins are, burnishing them closed. Or smooth, how about that? So lots of hemorrhage still, that's okay. We've irritated the gingiva quite a bit. This actually looks low, but intraorally it looks pretty much the same. So what I wanted to do is I'm going to take this rubber dam off, and I'm going to show you just a little tip what I do. We'll take that off, and then we're going to ask the patient, not so much, I mean, it'll be the standard, don't bite down, it might break. But it's going to be more of lightly bring your teeth together, because this side is numb, this side is blocked. I don't think it's in, I think I brought the microscope into, okay, so let's clean that up. Brought it into focus just for this. So what I'm going to do is I'm actually going to get the patient to slowly bite down, and what I'm asking them to do is, how does it feel on your left side? Does it feel like your teeth are contacting normally? And the patient will be like, yeah. You can see him say, yeah, it is. So then I'll take the paper, because if it's because they're not numb on the left side, so they can feel it like normal, and like, yeah, it feels normal. Then I'm like, okay, let's take the paper, take a look. Looks okay. Bite down harder, squeeze. Okay, we're good. Now, I'm happy with that restoration. It does not look, I mean, it's not an amazing look. So we're just checking, make sure his other side is contacting. When I get the patient to bite down right here, I'm also looking to see, let's go here, I'm looking to see if these are all contacting, like closed, where it looks like they have wear facets. We're good. And then that's it. And then tell the patient, don't eat on that tooth for 24 hours. And that's it. Now, is that an amazingly textbook looking restoration? No. But is that going to function potentially for 5, 10, 15 years? Probably. Anyways, I'm super grateful you're here, and let me know, post some comments about how your restoration goes. Cheers.